Okay, up chapter 18, feeding, eating, and elimination disorders. I'm just getting my page there so I can walk through the book as we go through this. Okay. Okay, so all of these you have likely heard of. We have our anorexia nervosa. This patient refuses to maintain minimal normal weight for height and expresses intense fear of gaining weight. Some restrict their intake of food. Most of them restrict their intake of food. They do not want to gain any weight at all. The term anorexia is a misnomer because loss of appetite is rare. So they actually still want to eat. They're hungry. They just don't want to eat in fear of gaining weight. Bulimia nervosa is binge eating and purging, disturbance in the perception of body shape and weight. So these patients will actually eat and then throw up what they eat. And I was just telling, I can't remember if it was a class or a clinical group, about a patient that my husband had at McLaren who was only 70 some pounds, female, bulimic. They had to actually put her in restraints because she kept sticking her fingers down her throat and throwing up all over everybody. And then when she finally agreed to eat, she ate one green bean and then stuck her fingers down her throat because she didn't want to have that one green bean in her stomach. So it's really severe in some people. And then binge eating disorder. This is engaging in repeated episodes of binge eating, after which they experience significant distress, and that distress is typically emotional, feelings of guilt and shame, and just being really upset that they ate the way that they ate. So your biological factors, anorexia has a 60% heritability, and neurobiological, altered brain serotonin function. Those, again, we're finding that people with imbalances of serotonin obviously creates quite a few different things that can happen within the person as far as mental illness is concerned. Your psychological factors, anorexia is primarily in girls approaching puberty, and I would say that our stigma has a lot to do with that as far as what young girls are perceived to what they should look like. Behavioral theorists say positive reinforcement can actually cause eating disorders, so telling a teenage girl how nice and pretty, or how nice she looks, how pretty she is, how she's got a nice body, that positive reinforcement can actually encourage the eating disorder. And then our environmental factors, our culture, especially our American society, what does our culture tell us? That skinny is beautiful, and that's it. And peer behaviors and attitudes may influence, so especially again with the girls. But that doesn't mean that guys can't have this too, because I've actually known a couple guys that have had problems with anorexia specifically. So with our nursing assessment, we want to check out what their perception of eating is and their eating habits. We need to always be aware that our patient's worst fear is weight gain. So us just telling them that you need to gain some weight. You're small, you're little. You need to eat and get some weight put on you. This is their worst fear. So we have to be very careful with that. Our major nursing diagnosis would be imbalanced nutrition, less than body requirements. And then page 348 has our different outcomes for these patients. Be sure to go over the outcomes for a patient with anorexia. And then planning, provide immediate medical stabilization, because remember, these patients, especially if they've been severe, are going to come in with all kinds of electrolyte imbalances. And then once medically stable, address their underlying eating disorder. So medical comes before the psychological is what that is saying basically. And then our acute care for them, our psychosocial interventions, we're going to focus on eating behaviors and underlying feelings, and discussions about appearances that can be, be aware that discussions about appearances can be misinterpreted. So again, what we tell them may not be what they're seeing in the mirror. There's currently no medication approved by the FDA for anorexia. Integrative medicine, so massage, biofeedback, yoga to manage mood. Obviously, therapy would work for this patient, or would be encouraged for this patient. Health teaching and promotion, safety and teamwork. So with your bulimia, your general assessment, initially they do not look like they're physically or mentally ill. They may have swollen parotid glands, dental erosions, or caries. And patient may feel significant shame. So these patients, they know that they're eating and then throwing it up, and they may feel bad about what they're doing. So for us, we want to remain non-judgmental and be accepting of what of the patient's condition, as far as be accepting of the patient, and be non-judgmental in the best way that we can. And then your outcomes on table 18.4 for this patient. Make sure you go over those. I'm looking to see what page that's on. That is on page 354. And then planning, hospitalization for gastric rupture, electrolyte imbalances, or cardiac dysrhythmias. So, this patient can actually cause themselves quite a bit of damage from all the throwing up they're doing. So acute care, if patient is found to have a substance abuse problem as well, the substance dependence must be treated first. Therapy examines underlying conflicts and interruption of binge eating and purging. So again, remember that how we're going to take care of the physical needs first. This would also be the case if they were to have substance dependence as well. We're going to take care of the substance abuse before we take care of the bulimia. And then Prozac may help to prevent relapse. This patient probably is dealing with depression as well, but they find that Prozac may assist. That's going to balance out the serotonin. Counseling is more effective with bulimia versus anorexia because patient does see it as a problem. And health teaching and health promotion, relaxation techniques, healthy eating, exercise, and coping skills. So though I did say that with anorexia they could get counseling as well, again, remember the anorexic doesn't see it as a problem. The bulimic knows that it's not healthy, that they shouldn't be doing that. So we want to teach them relaxation techniques, healthy eating, exercise, and coping skills. So our binge eating patient, our assessment with them, the patient may be experiencing heartburn, dysphagia, bloating, abdominal pain, diarrhea, urgency, constipations, and feelings of anal blockage. Self-assessment, be aware of your reactions to obese patients. Personal reactions among nurses are still influenced by disgust or displeasure. So, if we have a patient that is severely overweight, they may not have been taking care of themselves. They may have sores. They may not smell very pleasant. Just be aware of how you react to these patients. There was a woman that, and I was in nursing school, we went in, they had like 4 or 5 nursing students come in because she was like 750 pounds, and they wanted us all to help to roll her because she couldn't roll. And, the nurses and the nursing students overall did a pretty good job actually of remaining objective and neutral, even though the lady did have quite an odor and had sores all over. I mean, and it took one person alone just to hold a breast. So, it's very difficult. Just imagine being that patient. Yes, their eating habits have gotten them there, but they're still dealing with that. So, like we've talked about with all of our patients, any of our patients, regardless of what they're going through, they are still going through it. So, they're still a human being who is going through whatever it is they're going through. Your outcomes or your imbalanced nutrition more than body requirements as your primary diagnosis for your binge eating patient. Your outcomes identification, I'm 357. Go over those as well. And then planning, management of GI tract dysregulation, because this patient goes anywhere from having diarrhea to having constipation. Pharmacological interventions, so diet pills approved for BMI greater than 30. Belviq, patients feel full after eating small meals, but it's only recommended for 12 weeks. And Qsymia, Topamax, and phentermine. So, the Adipex is the phentermine. Topamax is one of our medications we use for bipolar, but they also find that it suppresses appetite. It's not a great, and this is just my opinion, but it is not a great medication for appetite suppressant because it is a psychiatric medication. Surgical interventions, all obese persons do not necessarily have a binge eating disorder, okay? So if you were to see something about that, just because somebody is very overweight doesn't necessarily mean that they're a binge eater. And then this is something that I found interesting. Research showed that relationship between binge eating disorder before and after surgery, that 12 months after patients who had most severe binge eating demonstrated the most improvement. So after they had the surgery. So I thought that was pretty interesting. I mean, I guess when you reduce the size of the stomach, that's going to make it so the binge eating would no longer be able to occur because clearly they would either throw up or feel horrible. So I thought that was an interesting little thing that was in there. So feeding disorders, pica. You guys probably learned about this during OB, that some pregnant women experience that. So it's eating non-food items after maturing past toddlerhood, and it's not part of any other mental illness. Rumination disorder, this is regurgitation with re-chewing, re-swallowing, or spitting, and again, not part of any other mental illness. So this is bringing your food back up, chewing it again, and swallowing it again. Um, and then avoidant restrictive food intake disorder, avoiding or restricting foods starting in early childhood. These people typically have a significantly lower BMI. There is actually no distortion of body image, and they can end up being dependent on enteral feedings or experience nutritional deficiencies. So this can be a very serious thing. Elimination disorders. So enuresis, this is a behavioral disorder in children who are developmentally older than 5. It's involuntary or intentional urination into clothing or the bed, and occurs 2 times a week or more. Occurs 2 times a week or more for more than 3 months. So, this is going to be a kid who's over 5 years old, and it's happening, obviously 2, 4, 6, 8 times at least per month for more than 3 months. And then encopresis. This is behavioral disorder in children who are developmentally older than 4. This is involuntary or intentional inappropriate passing of feces, and occurs once a month for more than 3 months. And that's it for that chapter. I will finish this one up and then we'll do our last one, and we'll be all set.